Hi, good morning, everyone. Welcome to the final webinar of the Vasculitis month series, organized by ERN-RITA in collaboration with EUVAS. My name is Kasia Wawrzycka-Adamczyk. I represent autoimmune vasculitis stream in ERN-RITA, and together with my co-chair Beatriz Sanchez Alamo, who represent EUVAS, I am delighted to moderate today's session. Today's topic is personalizing immunosuppression and care pathways in ANCA-Associated Vasculitis. It will consist of two 20-minute expert talks, followed by approximately 5 minutes of discussion after each of it. So before we begin, a quick practical note. Participants are warmly encouraged to submit questions through the webinar using the Q&A session. We'll collect them during each talk and address as many as possible. So it is my pleasure to introduce our first speaker, Jolijn van Leeuwen. She's a physician scientist at the Leiden University Medical Center, where she conducts research within the Expertise Center for Lupus, Vasculitis and Complement mediated disorders. In her research, she focuses on innovating treatment and digital health solutions. Jolijn, the floor is yours.
Oh, thank you so much. I will share my screen. So indeed, I'm gonna talk about how we can improve care, how we can make it smarter, more digital and more personal. And I will share our experience with implementing digital care pathways and how that impacted the care for the ANCA-Associated Vasculitis patients. Well, why do we need improvement of care of ANCA-associated vasculitis patients? I assume everybody knows ANCA-associated vasculitis and knows it's a complex chronic disease. And there's a big differences in presentation. Some patients present themselves with a lot of complaints from the ENT department, but other patients almost have no complaints. In addition, there's a large differences in disease courses. Some patients will relapse quite frequently, while other patients will stay in remission for 10 years and only relapse after that. And some patients may never relapse. This also makes it difficult to personalize the treatment because we cannot just give everybody a high dose of immunosuppressives, because there's also a high risk for treatment-related complications. And this altogether makes patients that they need lifelong specialist care. But then there's also a problem with that, because there's an increase in constraint put on the capacity of specialist care. So we cannot just see every patient frequently during the whole year. So I think what we should want is to see patients at the right time. So also when they have complaints start between the visits, we shouldn't wait to the next visit. We'd be able to see them as soon as possible. We would like to treat only the patients that really need treatment, to really personalize the treatment and reduce relapses, but also prevent treatment toxicity. But in the same time, we also have to try to reduce the pressure on the specialist capacity. And one of the solutions we saw for this is smart care pathways. And I will tell you something about our experience with that. But what do smart care pathways do? Smart care pathways have multiple items which combine together. So they have structured care pathways, which means it is structured when a patient should have a visit at the hospital. And it also includes an annual extensive review at the nurse practitioner. So every year, patients will be there at least once. And it also encounters risk-based stratification, which means that patients with a higher risk profile need more visits than patients that have a lower risk profile. So this is incorporated in the structured care pathways. In addition to the care pathways, we have the digital monitoring of the patients. So all patients have an application on their phone, which we use to send out EEV-specific questionnaires, which include the PGA, so the Patient Global Activity Assessment, where they score their own activity from 0 to 10. But we also send out the questionnaire, the AAV Pro, which combines questions on disease symptoms, but also on quality of life. And we also ask about productivity. So we can, with these questionnaires, we can early detect the start of new symptoms, but we can also monitor the quality of life and productivity of these patients. Then the last important part of the smart care pathways is the smart decision support. And for now, we have two types of smart decision support. We get recommendations to determine the risk level of the patient. And in addition, we get alarms for warning signs based on the questionnaires. So how does the smart decision support work? We use the technology from their health, and they have the their recommender. The their recommender collects real-time data, both from the laboratory of our hospital, but also from the patient using the application on the phone. So it continuously checks if any data has rose above a predefined threshold. So this can either be a questionnaire score that goes down, or a laboratory score that goes up above a specific threshold. And when this is reached, a notification will be sent out to the healthcare providers. And this can be either checked by the nurse practitioner or checked by the physician itself. And in our case, we have a nurse practitioner who checks all the notifications every day to make sure nothing new happens that needs immediate attention. And when a notification or recommendation is sent out, the physician or the nurse practitioner always have the opportunity to either accept or reject the notification or the recommendation. And the physician always stays in the lead to determine the action, which makes it really safe for the patient. When the alert is sent out is defined also by the medical team itself in combination with their health. So you have really a lot of control over this. I think we can distinguish 4 different types of smart decision support. We have the rule-based, which means the physician will answer a few questions and then a recommendation will be sent out. It can be questionnaire-based, based on the scores the patient fills in. It can be laboratory-based if any specific laboratory results reach a threshold. But of course, you can also combine these items. And when you combine data sets, you can also think about prediction models. At this point, we only have 2 types of decision support. We have a recommendation for the pathway selection to determine the risk profile of the patient. The physician can start this recommendation process, and he will have to answer 3 or 4 questions about previous relapses, about the current treatment, about the organ involvement, and about if it's a PR3 of an MPO patient. And based on the answers, their recommender will give you a recommendation to either have a high risk or a low risk maintenance pathway. And again, the physician can either accept or reject this. And if it rejects it, you can just choose a care pathway manually. In addition, we get notifications for low scores. So when a patient completes a questionnaire, the DARE recommender checks 2 of the outcomes, the overall health assessment, which goes from 0 to 100%. And if it's below 60, it will send out a notification to the nurse practitioner. And if the PGA, which goes from 0 to 10, is above 5, so then the patient would consider their disease activity pretty active, it will also send out a notification. And the nurse practitioner will look at the notifications and determines the action. If patients don't have a visit soon, she will either organize a visit or maybe call the patient to determine what the correct follow-up would be. Or she can also send out an additional questionnaire in a few weeks to really monitor the complaints. So this is what we implemented till now, but our implementation strategy actually has 3 stages. So the first stage, and we implemented stages because we didn't want too big differences, because then we were afraid the adoption for both the patient and the physicians wouldn't be great if the changes are too big. So we start with small steps, and we work up to stage 3, which has more impact. So the first stage is structured care. So we implemented the digital care pathways, we standardized the workflows, and we started with the remote monitoring. For now, all appointments remained physical or didn't change compared to previously. But the decision support is rule-based on the questionnaires, like I just said. And we continuously tried to improve the adherence by checking if everything was working and how it should be improved. So we had optimal clinical integration. And now I will show the impact analysis on this part of these 3 years, 2023 to 2025. And currently, we're working on stage 2, the adaptive care, where the decision support will be a bit more complex based on trends in the laboratory or trends in the questionnaires, and where we will try to make appointments digital when possible, so change physical to telemonitoring appointments when patients are stable. And then the next stage, hopefully maybe starting in 2028, will be further optimization of digitalization and personalization of care, maybe even using predictive models. And maybe then we can only see the patients physically when we really need that, and mostly monitor them digitally. But first, let's look at how the first stage went. So that was started in 2023, and we looked till on for 3 years what the impact was. In these 3 years, we had 221 patients at our outpatient clinic, and although we tried to start as many patients as possible with the smart care pathways, in the end 128, so almost 60% of them started. And after the start of the care pathway, patients had to get a mobile application and fill in questionnaires. But as you probably all know, ANCA-Associated Vasculitis patients are often a bit older. So this didn't always work, but in the end, almost 80% of them were able to start the application and fill out questionnaires. We also did a small comparison between the patients who did start and who did not start. And there we saw that patients who did not start care pathways were often a bit older, had a longer disease duration, and had less recent disease activity. So they were often more stable. Then we can look at which care pathways were started. And in total, more than 300 care pathways were started. And most of them are maintenance care pathways, as expected, because luckily most patients are in the maintenance phase. And within the maintenance care pathways, we see mostly high-risk pathways, which means we will see patients every 3 months. When we look at the annual visits per care pathway, as expected, we see a higher amount of annual contacts at a high-risk care pathway than in the lower-risk care pathways. But it's also important to notice that the difference between the high and the low-risk care pathway is even a bit bigger than predefined in the care pathways. So this means that also the patients in the higher-risk care pathways had more unexpected visits or contacts with the healthcare provider than the patients in the low care pathways, which means we seemed successfully identified the patients who were in a low risk profile, who didn't need much contacts during the year. And then we also looked at the smart decision support. So the recommender was used 77 times in 51 patients. And in almost 80% of the times, the recommendation was accepted by the physician. When the recommendation was not accepted, we saw in 7 patients that a higher risk profile was started, and in 5 patients, a lower risk profile was started. And in 2 patients, no risk care pathway was started. But luckily, most of the recommendations were accepted. Then we also looked at the questionnaires. So over 3 years, we collected more than 900 questionnaires. And we saw that most of them did not trigger any notification, but around 25% did trigger a notification. And then we looked at the number of contacts following a questionnaire in the next 3 months. And we plotted this against the health index score. So a health index score of 100% is really good, and below 50 is pretty low. And indeed, we see that a patient with a low health index score need more contacts with the healthcare provider in the 3 months after filling it out. So there's a connection between the scores reported by the patients and the healthcare utilization. And then we also looked at the notifications. So after a notification, there was a higher risk of having multiple contacts with a physician in the next 3 months. So a high healthcare utilization was almost 3 times as high for after notifications than after a questionnaire without a notification. So we seem to identify patients who are in need of healthcare utilization. Then, of course, we also have to look at relapses. In ANCA-Associated Vasculitis, maybe one of the most important outcomes, but luckily this was really low. So there were only 13 patients that had a relapse during one of the maintenance care pathways. And we indeed see that these are mostly in the maintenance high-risk care pathways and fewer in the medium and low-risk care pathways. Of the 13 patients, 6 patients filled out at least one questionnaire in the 3 months before the relapse. And all of these questionnaires triggered a notification, helping us to identify the patients who were having complaints. For 3 patients, we had multiple questionnaires, so we can look at the trends. And all 3 patients, we see a clear decreasing trend actually already in the months before the relapse. So this really shows we can really see the complaints in the health index scores. Then the last thing we looked at was the healthcare utilization. Because we for this we compared the 3 years before the digital care smart care pathway, so 2022 to 2022. And then the 3 years during the smart care pathway, so 2023 till 2025. And we see that before the care pathways, the annual visits were around 6 to 6.5 visits per year per patient. But since the implementation of the smart care pathways, we see a clear decreasing trend, which decreased to only 5.3 annual visits per patient per year in 2025. So this is almost a 16% reduction compared to before the smart care pathways. And in addition, we also looked at who was giving the care, who provided the care. And we separated this in the specialist, the acute officer. So if the patients call to the outpatient clinic with specific complaints and they will have an extra visit, they will also often be seen by an acute officer. And then we also looked at the nurse practitioner. And indeed, we see that since the implementation of the care pathways, we see an increasing trend of care delivered by the nurse practitioner, going up to almost 20% in 2025. And when we combine these numbers, we see a 32% decrease in contacts with the specialist during the year. So that's a pretty big decrease in contacts. Then lastly, we also wanted to see if the quality and safety for the patients remained. To look a little bit for guidelines adherence, we looked at the cholesterol screening for each patient, which should be done approximately once a year. And in the years before the smart care pathways, we see there's not a lot of screenings being done. And since the start of the care pathways with the annual extensive review at the nurse practitioner, we see a big increase. which hopefully helped to improve the cholesterol management. And just to be sure, we also looked at other forms of healthcare utilization, including visits at other EUV specialists, but also at admissions, day treatments, and ER visits. And luckily, we did not see an increase in either one of those, suggesting it was also safe. So going to my conclusions, I think we've showed that smart digital care pathway technology led to the successful risk stratification based on risk profiles and well-accepted decision support. We were able to early detect patients who were at high risk for escalation of healthcare utilization, and we saw a de-escalation of the annual contact with the healthcare provider and also increased involvement of the nurse practitioner. And I think this is a nice first step into smart, digital, and personalized care, while also freeing up variable specialist capacity. But as I said, this is only the beginning. So I'll give you a small look back into the future. As I said, the next step will be stage 2, the adaptive care. And what we're currently working on implementing is that we will get new smart decision support, which will send out a notification when the ANCA goes from negative to positive, or when it increases. We also have to look at the value, but probably by 50%. We will send out a recommendation to the physician to consider closer monitoring of these patients with laboratory results, but also with questionnaires to really make sure these patients are not having the beginning of a relapse. And in addition, when the health index is very stable, over 80%, we will give the recommendation to consider changing physical appointment to tele appointments, because these patients seem really stable. And then the next step will be even more predictive care. So then we hopefully will be able to maybe predict the relapse risk of patients, but also the treatment toxicity risk, and maybe importantly the infection risk. And maybe we can use the Paradise prediction models for this, and that's what Mark has been working on, the next speaker. So he will tell you more about that. But before we will do that, I want to acknowledge my colleagues, because implementing new way of care only works when you have a good implementation team. So I'm very thankful for all the people working on the implementation, both on our side of the outpatient clinic, but also the support from the Dear Health company. That was my presentation. Happy to answer any questions.
Thank you. It was a very impressive talk. Congrats for all your research. I'm really impressed by the use of smart care pathways in AAV. If the audience have any questions, please just share them into the chat. There is from one of the attendees a link that perhaps it will be interesting to read afterwards. Cecilia, she's sharing an article, so perhaps could be good to read after this session. But in the meantime, I would like to ask you, how did you implement this strategy in your center? Did you need to convince your IT department? How was the implementation of this?
Yeah, that's always a good question, and one of the most difficult parts of really trying to innovate care, I think. Indeed, we needed the support of our IT department to connect with the Dear Health application, because it's important there's a connection, and it's not just two completely separate platforms. So that took some time, and then but they were very helpful with that. And after that, it took some time to design the care pathways for ANCA-Associated Vasculitis, because we did want it to be AAV specific, so we could really monitor these patients specifically on their complaints. And all the physicians were pretty enthusiastic to work with it, but then in the end, when they're having a very busy outpatient clinic, they will need help to really implement it. So that was one of the things we really try to help them with.
And perhaps have you thought about any other strategies to engage these patients, like the elderly patients who are not that compliant with this system, to overcome all these, these burdens?
Yeah, so we do give the possibility to put the application on the phone of a caregiver, so either a partner or the children, anyone who wants to help, and then they can fill out the questionnaires together. But in the end, we do see that just a lot of the really older patients above 80 are often just not really interested, and then we also don't want to if they don't want to, it will not work. So we just keep the care as we have it and try to keep it as good as possible. But we do try to convince patients that this will really improve their care, that we do it for them and not that they have to do it for us.
Can I also have a question? I would like to ask more about the resources you needed to create the time and human resources you needed to construct this and maintain.
Yeah, so the building of the care pathways I did while doing my PhD, so it was also part of my PhD research. We did it together with a nephrologist, Professor Teng, and the nurse practitioner. And I think one of the important things is that the nurse practitioner is in the lead. So this is really one of her focus points during her job. So that makes to have it high priority. But it also takes a lot of, it makes sure the specialists don't have to do the monitoring, but also that they have less visits at their outpatient clinic. So that's a double positive, I think, putting the nurse practitioner in the lead.
Thank you.
Okay, thank you, and congrats again, Jolijn, and I wish you a lot of success in the next steps of your research.
Thank you so much.
Thank you, Jolijn. Now I would like to introduce our second speaker, Professor Mark Little from Trinity College in Dublin. Mark is an international recognized expert in vasculitis and nephrology whose research contributed to better understanding the small vessel vasculitis mechanisms and treatment strategies, the leader of such projects as FAIRVASC, evaluating the usage of urinary biomarkers in vasculitis and creating the animal model of autoimmune vasculitis. Mark, the floor is yours.
Thank you very much, Kasia. You can hear me okay?
Yes, perfect.
I'm delighted to close this Vasculitis Awareness Month series. I think its collaboration between EUVAS and RITA is a great example of effective collaboration in healthcare. And I will follow directly on, develop some of the concepts that Jolijn described to think about personalization of immunosuppression, ANCA-Associated Vasculitis. I do have a few disclosures. So what about AI-enhanced medicine? This has been promised for a long time and is clearly starting to gain traction. With this comes concerns about energy use, source of training data sets, how it will function in the clinical pathway, as Jolijn has just described. An LLM-enhanced Google search is now provided by default. Do we actually believe what it says? Do we check out the sources? And importantly, how will we work as doctors alongside these AI enhancements, seamlessly keeping the human not only in the loop, but piloting the ship? Will we appraise the tools like we now appraise the literature, understanding the information going into them? As Jolijn has described, relapse of ANCA-associated vasculitis is frequent, often recurrent, but preventable with maintenance therapy. The strongest risk factor for post-diagnosis end-stage kidney disease is occurrence of a renal relapse. As well as exposing the patients to additional induction immunosuppression, relapse of AAV may thus have severe clinical consequences. Therefore, both EULAR and ACR guidelines recommend rituximab maintenance therapy, variously ranging from 24 to 48 months, but further definitive guidance on this is lacking. There are clearly individuals who successfully remain off treatment for many years without relapse, and conversely, those whose immune system remains activated and primed to cause injury shortly after withdrawal of immunosuppression. And I think that in such heterogeneity lies the opportunity for a personalized approach. For example, imagine the gentleman on the left in your clinic, NPO ANCA, renal limited, treated with rituximab, and now ANCA negative. Is it possible that he needs watchful waiting rather than reflexive maintenance therapy? On the other hand, consider the lady on the right with severe CKD in the setting of relapsing PR3 ANCA vasculitis. Perhaps she requires longer-term therapy, potentially lifelong. I think that this choice is a personalized one that integrates multiple static and dynamic factors to estimate future relapse risk. This plot shows the multifaceted clinical course of a 64-year-old man presenting with kidney failure and hemoptysis in the presence of a high-titer anti-MPO antibody and treated with rituximab and oral corticosteroids. As a clinician planning type and duration of maintenance therapy, there are 3 checkpoints. Firstly, there are static factors that are evident at diagnosis that help the physician to stratify the patient into broad relapse categories. Secondly, post-induction, we have additional static information to refine this choice. For example, we know how the patient responded to the initial therapy and what happened to the ANCA level. Thirdly, and this is where much of our decision-making resides, we need to make multiple choices as the patient moves through time, balancing relapse versus remission, considering dynamic time-varying factors such as biomarkers and some knowledge of prior events such as relapses, which influence future relapse risk estimates. I'll explore how we balance remission and relapse over these 3 checkpoints, considering static baseline predictors, post-induction predictors, and dynamic factors supporting treatment withdrawal, and consider whether these can be tied together into a physician support tool along the lines of Jolijn's presentation. Firstly, we know from the NORAM trial of patients with GPA some time ago in the pre-rituximab era that over 50% of patients with GPA relapse quickly when this therapy is discontinued at 12 months. Similarly, in the non-rituximab treated patients receiving azathioprine maintenance therapy, about 45% relapsed by 5 years in this analysis using old EUVAS trial data. And many studies have examined this static baseline stratification into high or low relapse propensity. And this post-hoc analysis of the PEXIVAS trial data is a recent example, which confirmed PR3 ANCA specificity, use of IV cyclophosphamide induction therapy, granulomatous respiratory tract inflammation, and good kidney function as the 4 key driving factors. The probability of relapse increased with cumulative addition of each of these factors. I'd like to ask now whether there are immunological correlates of this baseline relapse propensity. And this study from the University of Cambridge forged the path in this field. It's a pre-rituximab small cohort study that performed transcriptomic analysis on purified CD8 T cells at diagnosis, identifying a module called 8.1, which was characterized by a certain type of T cell expansion with IL-7 receptor activation. And patients with this module experienced an extremely high relapse risk. This was followed by another study from the same group, published in Nature, that examined multiple autoimmune diseases, including the same AAV cohort, and described an exhausted CD8 phenotype, characterized by high expression of immune checkpoint molecules like PD-1, which appeared to be protective against relapse. Now, translating this pretty advanced technology into clinical practice is not straightforward. So Andreas Kronbichler looked for blood-based immune checkpoint proteins that may act as a surrogate of this T-cell exhaustion signature using samples from the RAVE trial. He found that high levels of soluble TIM3, CD27, and BTLA, 3 markers of immune exhaustion, elevated levels of these at diagnosis also correlated with a very low relapse propensity. Interestingly, this effect was primarily seen in PR3 ANCA positive patients and was also not seen in those treated with cyclophosphamide. So at checkpoint 1, we can get a rough idea of which relapse risk basket our patients rest in. And it seems that a key immunological determinant of this is the degree of T-cell exhaustion or activation at presentation. And when the patient reaches point 2 in their trajectory, about 6 months post-diagnosis, more information is available to help refine the future treatment strategy. Firstly, we know in patients with glomerulonephritis whether the hematuria has disappeared. In fact, at 6 months, this happens in fewer than 25% of those with renal involvement, with dipstick blood and protein continue to improve well into the 2nd year. And in this study of 149 patients with prior vasculitic glomerulonephritis by Rennie Reed, also replicated using the main RITA trial data, this persistent microhematuria was associated with a 4-fold increased risk of renal relapse, a feature not observed with persistent proteinuria. A key piece of information also available at 6 months is what happened to ANCA. This was nicely assessed in this emulated trial study from Zach Wallace's group using real-world data from Mass General. This statistical technique simulates an interventional trial where the intervention is achievement of serological remission, i.e. becoming ANCA negative, versus not reaching this state. And using this simulation, remaining ANCA positive was associated with a 50% increase in subsequent relapse risk, with interestingly a similar magnitude of effect in MPO and PR3 ANCA patients. A more extreme take on this was published by the group from the Mayo Clinic, looking at patients with MPO ANCA kidney involvement. They found that as long as the ANCA remained persistently negative after induction in this patient population, no relapses were observed. We adapted this approach slightly using data on patients with MPO ANCA AAV from the Irish National Register, asking the question of whether becoming ANCA negative post-induction and remaining so up to 18 months influenced relapse risk. This was indeed associated with a significant delay in relapses, but they clearly did occur. However, when you stratify by induction therapy, it does appear that becoming MPO ANCA negative post-rituximab is associated with a very low relapse risk over 5 years. And a bit like AI in our society today, combination rituximab and cyclophosphamide for severe disease has been creeping into practice and even some guidelines. The Turin group in Italy have adopted a combination treatment protocol for severe ANCA-associated glomerulonephritis, which mandates no maintenance, 0 maintenance, if the patient becomes anti-MPO negative. And they've had good results with this approach. This reinforces the sense that persistent anti-MPO negative disease may not potentially require any maintenance therapy in the rituximab era. What about myeloid cell activation in this neutrophil and monocyte-driven disease? Recent evidence was generated through this fascinating study from Japan. Using a multi-omics approach, they identified distinct subsets of monocytes that appeared to align with clinical phenotype. One subset, they termed MPA mono, was characterized by highly activated monocytes with high calprotectin transcripts. These patients were treatment resistant and had more severe renal involvement. A second subset displayed features of type 1 interferon exposure and was found in patients with ENT and skin-dominant disease that was very treatment responsive. Attempting to translate this into clinical practice, it appears that the activated monocyte group in pink correlated with simple peripheral monocyte count, and the interferon-exposed group with the level of interferon alpha in the blood. Virtually all of the subsequently observed relapses were in this MPA mono group. Now, this needs to be replicated in a larger population, but provides a glimpse of a potential future personalized approach. Now, an important decision that emerges at this stage, and which is influenced strongly by the physician perception of relapse risk, is the mode of rituximab dosing. Most recent guidelines advise programmed dosing every 4 to 6 months. However, in practice, we as physicians regularly perform risk assessments in collaboration with our patients. This ranges from strategies that dose regularly, dose on return of B cells, on return of ANCA, or indeed return of clinical vasculitis, with escalating risk as we move along this path. Although underpowered, the main RITA-2 trial showed a subtle increase in relapse risk with a treat to ANCA or treat to B cell rise approach. This was further underlined by a clear observed reduction in major relapses following a programmed redosing approach in a meta-analysis of the main RITA trials from France. But of course, this approach comes with the patient and economic cost of high rituximab usage. So to summarize checkpoint 2, persistent urinary blood may reflect ongoing subclinical intrarenal inflammation, and how the ANCA behaves during induction further refines relapse risk estimates. Persistent myeloid cell activation also portends relapse, and the estimation of relapse propensity and our attitude to risk intimately affects how we dose rituximab. Now, we are several years post-diagnosis at checkpoint 3, and we have knowledge of the prior clinical course, including the integral of cumulative treatment exposure and prior relapse events. A key decision at this point is treatment withdrawal, and the factors influencing this decision change with each patient encounter. Of course, we know from the REMAIN and main RITA-3 trials that treatment withdrawal is generally associated with a relapse signal, even 3 or 4 years out. This forces us to balance the risk of permanent damage from these relapses, which may of course be minor and controllable with rapid treatment reintroduction, against the toxicity and cost of ongoing therapy. In a carefully designed real-world study of patients with GPA from Cambridge, Mark McClure studied the risk factors for relapse that pertained at the time of rituximab discontinuation. At the time of the last dose, having ENT involvement was the strongest relapse predictor, while more importantly, the strongest predictor 12 months after the last dose, which in fact is effectively roughly when the rituximab was truly discontinued. The strongest predictor at this point was being ANCA positive. Now, the issue of regular ANCA monitoring and its link to disease activity divides the vasculitis community. Many studies have looked at this, but this cohort analysis from Michael Kemna, a few years old now, summarizes the general message in my view. Patients with renal vasculitis and an ANCA rise had a markedly higher relapse rate than those without renal vasculitis and an ANCA rise. This explains why I, as a nephrologist, tend to value serial ANCA monitoring, while non-nephrologists tend to value this less. This study gets closest to modeling the dynamic nature of ANCA level in an irregular time series, which is a major statistical challenge. However, neither this model nor any other in the literature, to my knowledge, considers multiple relapses and the effect that each might have on future events. And this, I think, is the direction we should be moving in. We have had a go at this using the Irish data and a machine learning technique called PWP-GAP, which allows for recurrent events. We examined the impact of a switch in ANCA status on the risk of relapse in the subsequent encounter. 30% of those with a neg to positive switch relapsed. And in the multivariate analysis, negative to positive status was the strongest independent predictor of that relapse. And looking upstream from the ANCA at the cells leading to its production, this study used serial RAVE trial samples and studied the small population of autoantibody producing plasmablasts specific for PR3 emerging post-rituximab treatment. This is a pretty technically tricky challenge to do, but they found that enrichment of these autoreactive cells was clearly associated with relapse. So to summarize checkpoint 3.
Mark, I'm sorry, I think there is a small reminder there popping up and we cannot see the whole slide. Is there?
Sorry.
That's okay.
Okay. Thank you.
You're welcome.
Summarizing checkpoint 3, attempts at treatment withdrawal are often made 2 to 3 years post-diagnosis. No current biomarkers accurately identify ultra-low relapse risk post-treatment withdrawal, unfortunately yet, but dynamic ANCA status is important, particularly in ANCA-GM. So we are developing increasingly sophisticated estimates that help us to balance relapse versus remission at various time points in the clinical course of the patient. Emerging biomarkers need further validation before translating into clinical practice, and we need to improve the methods by which we integrate the increasing range of static and dynamic factors to generate clinically useful risk measures that move through time with the patient. And this is the focus of the ERN-RITA Paradise Consortium, which seeks to generate decision support tools to aid physicians at checkpoint 3. Using multiple international data sets, we are training machine learning models to integrate static and dynamic predictors, such as point-in-time treatment intensity and prior relapse history to provide 18-month relapse probability, calibrated to identify with high accuracy those at ultra-low risk of relapse and to increase confidence in treatment discontinuation. We are now seeking to embed this algorithm alongside a live electronic health record to link in with Jolijn's talk. We hope to ingest both static and time-linked variables into a pipeline that runs through an algorithm based on ordinary differential equations, landmarking, and a large language model to predict the next phase of the patient's timeline, moving with the patient as they move through their disease course. The outputs of this will be fused with patient-reported outcomes to assign them to one of 3 care pathways as described by Jolijn, ranging from nurse-led care to frequent doctor assessment, and to identify those in whom immunosuppression can be stopped safely. So what does the future look like for our patient with a relapsing PR3 AAV? She's now at checkpoint number 3, her current relapse risk being influenced by the integral of prior events. I believe that her AI-enabled care will be supported by a dynamic, time-sensitive, explainable, algorithm-guided decision support tool, so that future shared treatment decisions are truly personalized. And thank you very much for your attention. I'll be happy to take any questions.
Thank you, Mark, for a brilliant talk, as always. I think we have a small question from the audience related to the CD19. What is your opinion, your views in measuring CD19 in all the patients or perhaps only non-responders?
So, yeah, as I mentioned, the decision to measure CD19 and treat to it is gone along that risk pathway. And I think if you adopt an approach where you want to redose according to the CD19, then you should be measuring it. However, if you are routinely redosing every 6 months or so, it's probably not necessary, apart from the initial CD19 count, to ensure that the patient has responded to rituximab in the first place. It's probably not necessary to measure it that regularly. But if you're going to use it in your clinical decision, then yeah, yes, it probably is worth measuring.
Thank you. You comment on like non-invasive biomarkers. But which is your opinion about performing follow-up kidney biopsies during patient monitoring? Because we know about the ANCA-RITA score that has a very good correlation with the outcomes. What are your personal views on this?
Well, I think, to be honest, I think this is the main question for the community. And we do have plans with colleagues in Ireland and elsewhere to initiate a routine rebiopsy strategy and to assess, say, for example, 6 or 12 months post-diagnosis, whether there is persistent renal inflammation. We know that in lupus, for example, that's definitely the case, that people you think are in remission actually are not. So I think we will be moving that way. But I think we'll be using, hopefully, what we find in this repeat biopsy study to identify urinary biomarkers that will correlate with what's going on in the kidney.
Thank you, Mark. Perhaps Kasia, may you have one question or?
I would like to ask, do you see the role of any genetic analysis at the baseline that can attribute to the predicting outcomes?
Yeah, so I mean, AAV is obviously a polygenic disease, and there's no one genetic feature that is either associated with relapse or the disease itself. So there's no place that can get present to routinely measure genetic factors. It may be that a combination of various gene SNPs might be associated with a higher relapse rate, but certainly not enough at present, I think, to merit measuring in the clinic.
Good. Well, if there are no other questions related to this topic from the audience, I would like to thank Mark for his brilliant talk. And I hope
there are 2 more questions, actually.
yeah, but perhaps they are not really related to the topic. Yeah,
Fine,
if you
that's
wish,
fine,
I can.
Yeah, I'll answer them just
Good. If not, if there are no any other questions, we would like to thank all the speakers for their excellent presentations and all the participants for joining today's webinar. We also want to acknowledge the important collaboration between RITA and EUVAS in supporting education and awareness about vasculitis. As we are celebrating Vasculitis Awareness Month, today's session is a good opportunity to continue sharing knowledge in our community. And before we close, we would like to kindly ask all the participants to complete our feedback survey. And thank you again for your participation, and we wish you a pleasant day.
Thank you very much.
Thank you.